And with that, we move to the next heading, pelvic fractures. Let me tell you up front the two problems that we can see of pelvic fractures. Then we'll read the vignettes, and then we're even going to review them again with a little decision tree. There are two issues in pelvic fractures. One is, it's one of the injuries from which you could bleed sufficiently to go into shock. People can bleed to death from pelvic fractures. The second issue is injury to nearby organs, the rectum, the bladder, and in the case of a male, the urethra. All right? Let's read the vignettes. In a rollover car accident, a 42-year-old woman is thrown out of a car, and subsequently the car lands on her and crushes her. At evaluation in the ER, it is determined that she has a pelvic fracture. She arrived hypotensive but responded promptly to fluid administration. CT scan shows no intra-abdominal bleeding and a pelvic hematoma. This lady is lucky. She's not bleeding to death from a pelvic fracture. We see the hematoma there, we leave it alone. Don't lose the tamponade effect that this hematoma already has. So all we have left on this lady is rule out the additional injuries. She needs a proctosigmoidoscopic exam to make sure she doesn't have a rectal injury. She needs a pelvic exam to make sure she doesn't have injury to her vagina. And she needs a retrograde cystogram to make sure her bladder doesn't have an injury. Now, if this had been a male, though, we would have also ruled out the injury to the rectum, but then the injury to the urethra would have had to be ruled out before we rule out injury to the bladder. We'll talk more about these on the vignettes that follow, and we'll review these a little bit more. So let me move on to the next vignette, vignette 35. In a rollover car accident, a 42-year-old woman is thrown out of the car. Subsequently, the car lands on her and crushes her. At evaluation in the ER, it is determined by physical examination that she has a pelvic fracture. She arrived hypotensive, did not respond to fluid resuscitation. Hemodynamic parameters have continued to deteriorate. Sonogram performed at the ER shows no intra-abdominal bleeding. She is bleeding to death into that pelvic fracture. This doesn't have an easy answer. You might say, well, why don't the surgeons do an exploratory lap and stop the bleeding? Hard to do. This is not the kind of bleeding where you see a pumping vessel, you can tie it. This is often oozing from all the raw surfaces of the broken bones or from a venous plexus that we have in front of the sacrum, and these are not the kind of bleeding sources that can be, easily controlled surgically. Well, you might have another guess. Well, then maybe an arteriogram should be done, an arteriographic embolization done, like we talked about for injuries in the upper part of the neck. And that works in roughly 1/3 of cases like this. 2/3 of the people that are bleeding to death from a pelvic fracture are bleeding from veins, venous plexuses, and those are not accessible via arteriogram and embolization. And probably the best answer, not a perfect one, but probably the best answer is external fixation of the pelvic fracture. And this is sort of a general rule you can apply to other exam questions. If you realize when you read an exam question, the patient is bleeding to death from broken bones, if you immobilize those broken bones so they stop grating on each other, you may help control the bleeding. So probably your best answer for this vignette is external fixation of a pelvic fracture. Let me repeat these issues about pelvic fracture. We're going to do it with screens with words in them. So if we have a pelvic fracture and the patient is in shock and not responding to fluids, you have to verify first that the bleeding is not in the abdomen. You do that with a fast test or the older diagnostic peritoneal lavage. And surgery in that case is not the best answer. You can pick an arteriogram if it is offered, but better yet would be external fixation of the pelvic fracture. On the other hand, if If the patient with a pelvic fracture is hemodynamically stable, then what we have to do is check for associated injuries. The associated injuries are going to include, in the ladies, the rectum, the vagina, or the bladder. And the order in which you investigate these is irrelevant. But in the case of the males, we're talking about the rectum, the urethra, or the bladder. And in that case, we have to do the retrograde urethrogram first, and the bladder later with a retrograde cystogram. You can see in this picture a pelvic fracture. So if you had a vignette on the exam that said this individual has blood in the urine, you would recognize that this pelvic fracture is related to that. And it illustrates the point that we always have to check for those associated injuries when there has been a pelvic fracture. All right, we're now moving into the chapter on urological injuries. Essentially, you recognize this on the exam because a patient who has sustained trauma now has blood in the urine. The trauma was penetrating trauma. The location of the injury tells you what organ is responsible for the bleeding. So that when you see a gunshot wound right above the pubis, you know the bladder is what is bleeding. If you see a stab wound on the flank, you know the kidney is bleeding. But in the case of blunt trauma, the way you decide is by looking at the associated bony injuries, and we'll get to that in a second. So let me go through the vignettes. We're now on vignette 36. A young man is shot point blank in the lower abdomen just above the pubis. He has blood in the urine and no evidence of rectal injury. Vignette number 37, a woman is shot in the flank. When a Foley catheter was inserted in the ER, the urine was found to be grossly bloody. Well, you know what the problem is in each of these. And the first one, it is an injury to the bladder, and the second one, it's an injury to the kidney. And both of these are going to need surgical exploration. Now we move to vignette 38. A 22-year-old man involved in a high-speed automobile collision has multiple injuries, including a pelvic fracture. On physical examination, there is blood at the meatus. All right, here's what I advise you to do. When you read on an exam question that blunt trauma is followed by blood in the urine, look immediately and see what is the associated bony injury. The associated bony injury is a pelvic fracture. The blood is coming from the bladder in either men or women, and in the case of men, also potentially from the urethra. But the associated bony injury is rib fractures rather than pelvic fracture, then the blood is coming from the kidney. We'll get to one vignette illustrating that in a minute. So let me go back then to this vignette. 22-year-old man involved in a traffic accident has a pelvic fracture, now blood at the meatus. Well, you know that blood is coming either from the urethra or the bladder. It's very important here that the urethra be evaluated first by means of a retrograde urethrogram. Because if you begin putting a catheter to gain access to the bladder and do x-rays, you may, with that catheter, compound an existing urethral injury and make it worse. So the answer here is do a retrograde urethrogram. Now let me give you a little more detail on urethral injuries. Vignette number 39. A 19-year-old man is involved in a severe automobile accident. Among many other injuries, he has a pelvic fracture. He has blood at the meatus, a scrotal hematoma, and the sensation that he wants to urinate but cannot. Rectal examination shows a high-riding prostate. Now this is a complete description of a posterior urethral injury. And you know, of course, that what you need to do is a retrograde urethrogram. And the next vignette, number 40, reads, a 19-year-old man is involved in a motorcycle accident. Among many other injuries, he has a pelvic fracture. He has blood at the meatus and a scrotal hematoma. This is an anterior urethral injury. Let me emphasize again for both of these. So the important thing on both of these are urethral injuries. The important thing is in a male that has blood in the urine after trauma with a pelvic fracture, you always do the retrograde urethrogram first. Okay? Let's move on then to vignette number 41. A 22-year-old man involved in a high-speed automobile collision has multiple injuries, including a pelvic fracture. At the initial physical examination, no blood is seen at the meatus. A poorly informed intern attempts insertion of a Foley catheter, but resistance is met. Here is another version of the urethral injury. You should be alerted to it because a male has a pelvic fracture and blood in the urine, blood at the meatus. This case doesn't have that. But we have a male with a pelvic fracture. Somebody tries to put a Foley catheter and it will not go. That is evidence that there is a urethral injury. Don't try to keep pushing that catheter. Do the retrograde urethrogram. Now, vignette number 42, a 22-year-old woman involved in a high-speed automobile collision has multiple injuries, including a pelvic fracture. Insertion of a Foley catheter reveals gross hematuria. Well, now in a lady, you're not worried about the urethra. That very small urethra in women is very rarely damaged. So we are assuming here when you put together pelvic fracture and blood in the urine, because this is a lady, that's coming from the bladder. We don't need to check the urethra. So you put a catheter and you do a retrograde cystogram. But be sure that you look for the answer where you take pictures in two settings. You put the catheter, you fill the bladder with X-ray dye, you take pictures. And then you empty the bladder and take pictures again. Because if the bladder injury was at the dome of the bladder, you see it when you fill the bladder and you see it extravasate into the peritoneal cavity. But if the injury is at the trigone, at the base of the bladder, which in fact is the most common place, you're not going to see the injury when the bladder is full of dye because the extravasation is retroperitoneal, it's posterior, it's obscured by the dye that's in the bladder. That's why you take that second set of pictures. Empty the bladder, take pictures again. Now you're going to see the extravasation if you had that bladder injury at the trigone. Obviously, a repair then is needed for these bladder injuries. Now, vignette number 43 says a patient involved in a high-speed automobile collision has multiple injuries, including rib fractures and abdominal contusions, but no pelvic fracture. Insertion of a Foley catheter shows that there is gross hematuria. Now remember what I told you at the beginning. When you see blunt trauma plus blood in the urine, my strategy that I suggested to you, see what is the associated bony injury. If it is a pelvic fracture, think of the bladder, and in the males, the urethra. If it is lower ribs, think of the kidney. And most of these, all we have to do is a CT scan. Most of these blunt trauma to the kidney resulting in hematuria do not require surgical intervention and correction of a problem. So a CT scan is done. The CT scan identifies a few rare cases that need surgical intervention. Most patients, all they get is the CT scan. Now, vignette number 44. Not a common problem, but a fascinating little thing that might appear on the exam. A patient involved in a high-speed automobile collision has multiple injuries, including rib fractures and abdominal contusions. Insertion of a Foley catheter shows that there is hematuria, and retrograde cystogram is normal. CT scan shows renal injuries that do not require surgery. 6 weeks later, the patient develops acute shortness of breath and a flank bruising. Now, the nature of the event here was such that no one ever really looked at the area that was injured in detail. The CT scan said, we don't need to intervene here, this will heal by itself. No operation was done, but now here comes this surprise. A few weeks later, the patient is short of breath, has a flank bruit. And what has happened is the renal artery and the renal vein that go next to each other were in fact damaged. We didn't see it, we didn't recognize it at the time. An AV fistula has now formed between the two. You have the bruit, you have the congestive heart failure from this as a late lesion that was not recognized at the time. You know, another version of this vignette might be the same beginning. The blunt trauma, the rib fractures, the blood in the urine, the CAT scan that said we don't need to do anything. And then a month later or two, the patient develops hypertension. There was in fact a damage to the renal artery. It stenosed as it healed. And now you have renovascular hypertension. All right, let's keep moving. We're now on vignette number 45. A 35-year-old man is about to be discharged from a hospital where he was under observation for multiple blunt traumas sustained in a car wreck. It is then discovered that he has microscopic hematuria. And I have to read the next because I'm trying to make a distinction here between a somewhat similar presentation in two very different types of patients. Vignette number 46, a 4-year-old falls off his tricycle. In the ensuing evaluation, is found to have microscopic hematuria. When an adult has big-time trauma, and then a trace of blood in the urine, we don't worry about that because we know, in fact, we've just been talking about that, we know that renal contusion can lead to hematuria, that most of the times we don't have to intervene to fix it. And so the first of these two vignettes doesn't require any further follow-up. But on the other hand, a child with minimal trauma. Look what happened to this kid. He fell off his tricycle. And then he has hematuria, even though it's microscopic. This may be a sign of a congenital anomaly that makes this child very prone to injury with minimal trauma. And so a urological evaluation would be needed. And it would begin with a sonogram, and we'll talk about this more when we get to the urology section. We're now on vignette number 47. A 14-year-old boy slides down the banister, not realizing that there is a big knob at the end of it. He smashes the scrotum and comes to the ER with a scrotal hematoma the size of a grapefruit. He can urinate normally. There is no blood in the urine. We're not concerned, given those two last bits of information, that he's got a urethral injury. The only thing we have is that big swollen, scrotal content. The issue then becomes, is the testicle rupture or not? The sonogram will give you the answer. So the answer on the exam for this vignette is do a sonogram next. If the testicle is ruptured, it's got to be repaired. And the last of the urological trauma vignettes, vignette number 48. 41-year-old man presents to the ER reporting that he slipped in the shower and injured his penis. Examination reveals a large penile shaft hematoma with normal appearing glands. Now this is a vignette. It is pretty diagnostic for an injury that you might be misled by the story you get from the patient. Because when you have trauma to an erect penis, not a flaccid penis, but you have trauma to an erect penis, you might get what's called a fracture of the corpora cavernosa, fracture of the penis. And the physical finding is absolutely classical, is what I just read. There is a big hematoma in the middle of the shaft with normal appearing glands. These, in fact, are usually lesions that occur during intercourse with a lady on top. The lady sits on the penis inadvertently and breaks it in two. But the patient is too embarrassed to go and give all the details. And if you believe the story that he had a flaccid penis, fell in the shower, and you do nothing about this, the patient is going to have a lot of trouble. Because when you have a fracture of the corpora cavernosa, if you let that heal on its own, arteriovenous connections will develop during that healing process, and then erection will no longer be possible because erection requires arterial inflow without venous outflow. So we have to recognize that a patient is not going to tell you the details of how this happened. Recognize this injury for what it is and have the urologist do a proper repair as an emergency so that this problem doesn't develop. All right, let me repeat this. We're going to go through a little decision tree here with not my face on the screen, but the appropriate words. We're dealing with urological injuries, which means we have a patient, in the first case, that has blunt trauma and blood in the urine. The thing that I want you to do next is look, what is the associated bony injury? If it is lower rib fractures, but no pelvic fracture, it is a renal injury. Do a CT scan. But if it is a pelvic fracture, in a female patient, you think of bladder injury. In a male, you think of urethral or bladder injury. And always evaluate the urethra first in the male. Do a retrograde urethrogram. If it is negative, then you do the cystogram. But you do not begin in the male with a cystogram. We're now going to move to the extremities. Most of the trauma to the extremities in the context of a multiple trauma patient is dealt with as the last item of business. In other words, in a multiple trauma patient, we deal first with the life-threatening injuries, and only later do we, busy ourselves with the extremities. But there is an exception. If we think there is a major arterial injury on an extremity, we have to take care of that right away. So let me go through the vignettes that exemplify that. A 25-year-old man is shot with a .22 caliber revolver. The entrance wound is in the anterior lateral aspect of his thigh, and the bullet is seen by X-rays to be embedded in the muscles posterolateral to the femur. Now, you know, when you read that vignette, just from the description, that there is no way you can have a major arterial injury here, because you know the femoral artery in the thigh is anteromedial. This bullet tract is completely lateral. And so this individual doesn't need further evaluation, doesn't need further, extensive management. You clean that wound, you give him tetanus prophylaxis, and that's all he needs. Contrast that to the next vignette 2. 25-year-old man is shot with a .22 caliber revolver. The entrance wound is in the anterior medial aspect of his upper thigh. The exit wound is in the posterolateral aspect of the thigh. He has normal pulses in the leg, no hematoma at the entrance site. X-rays show the femur to be intact. He has no evidence of arterial injury. The pulses are there. He doesn't have expanding hematoma. But he has what we call anatomical proximity. That entrance wound was right where you know the femoral artery is. This needs to be evaluated. Historically, at one time, all of these had a surgical exploration. Then we gained the means to evaluate vessels radiologically, and the answer became do an arteriogram, but we don't even have to do that anymore, because now we have totally non-invasive ways to evaluate this vessel. We do what's called Doppler studies, duplex scanning, totally non-invasive tests that show the integrity of the vessels and the flow, and this way we can rule out an injury. But as we move to the next vignette, vignette number 3, you see that we have a different situation here. 25-year-old man is shot with a .22 caliber revolver. The entrance wound is in the anteromedial aspect of his upper thigh. The exit wound is in the posterolateral aspect of the thigh. He has a large expanding hematoma in the upper inner thigh. The bone is intact. You have evidence of arterial injury, that large expanding hematoma. You might have had evidence also if he had said that he has no pulses distal to this gunshot wound. And so this man needs a surgical exploration because it isn't going to be done just for diagnosis. It's going to be done to repair the injury that the vessel sustained. Now, vignette number 4 gives you another view of this particular issue. A young man is shot through the arm with a .38 caliber revolver. The path of the bullet goes right across the extremity from medial to lateral sides. He has a large hematoma in the inner aspect of the arm, no distal pulses, radial nerve palsy, and a shattered humerus. Well, you know he's got a vascular injury. You also know he's got a nerve injury. You also know he's got a bone injury. All of these are going to have to be fixed, and the question becomes, in what sequence do we do them? You think only of the biological significance of each of the 3 injuries. The emergency is on the vascular injury. But for practical reasons, the bone has to be fixed first, because fixing a bone requires rough handling, hammering and screwing and putting things together. Repairing a vessel is a fine, delicate piece of surgical, repair with magnifying glasses, with perhaps an operating microscope, with very fine sutures. That would be disrupted by the orthopedic intervention. So the sequence is stabilize the bone first, then put the artery together, and finally do the nerve. But that introduces an angle here, a new topic. Anytime we have delayed reconstitution of a vessel that was damaged, and we have an area of the body, particularly the forearm or the lower leg, that have been ischemic for a long period of time and then eventually get reperfusion, they are very prone to develop a compartment syndrome. So given the inevitable delay of repairing the vascular injury after the bone injury, this patient may also require a fasciotomy to make sure that a compartment syndrome doesn't develop. All right, so we're now on vignette number 5. In a hunting accident, a young man is shot in the leg with a high-powered big game hunting rifle. He has an entrance wound in the upper outer thigh that is 1 cm in diameter, and an exit wound in the posterior medial aspect of the thigh that is 8 cm in diameter. The femur is shattered. Let's talk a little bit about wound ballistics. The damage done by a bullet to human tissue is directly proportional to the mass of the bullet, and also directly proportional to the square of the velocity. Not to the velocity, but to the square of the velocity. So that faster bullets do a lot more damage than slower bullets. Most of the gunshot wounds we see in civilian practice are of the type that we call low velocity gunshot wounds. It's 1,000 feet per second or below. In those, essentially the injury is limited in those to the trajectory of the bullet. There is no extra energy to go beyond that. But on the other hand, what we call high velocity gunshot wounds, which is 3,000 feet per second or higher, which include military rifles like the AK-47, the M16, and the type of rifles you need to kill an elephant, big game hunting. Those produce a cone of destruction, which is what you see described in this vignette. You're told that this happened with a high-powered big game hunting rifle, and the description matches that. A teeny bitty entrance wound, 1 cm in diameter, a big 8 cm exit wound. Because in the high velocity there is a cone of destruction. The energy goes beyond the trajectory of the bullet. Well, in reference then to this vignette, the answer is that these wounds, high velocity, need very extensive debridement or even perhaps amputations because of a very, very extensive damage that they do to the tissues. Okay? And now we move to the last of this group of vignettes, vignette number 6. A 6-year-old girl has her hand, forearm, and lower part of the arm caught in the ringers of an old-fashioned washing machine. The entire upper extremity looks bruised and battered. All the pulses are normal and the bones are not broken. This is a classical example of a crushing injury. You need to think of all the things that would be crushed out of the cells. So hyperkalemia, myoglobinemia, from that myoglobinuria, potentially acute renal failure. And so you need to check the potassium in this little girl. You need to check the myoglobin in the blood and in the urine. If there is myoglobinemia, myoglobinuria, you need plenty of fluids, osmotic diuretics, alkalinization of the urine. But the other aspect which is brought up by these crushing injuries is, with all that damage to the tissues, particularly in the two critical areas, forearm or lower leg, there is going to be very likely a compartment syndrome that will follow, for which then fasciotomies will be needed. And this brings us to the end of the review from head to toe.